Good evening, colleagues. Good morning. I'm glad to see you all here in our webinar for listening the talk of Doctor of Science and Professor Ophthalmic Surgeon Dr. Oganessian. Crystal Vision Eye Clinics by Professor Igor Aznaurian today will show their interesting service for keratoplasty that we can hold in our clinic. We know that patients who need to make a keratoplasty is very they are not very much here in our patient schedule, but these patients need very careful and effective medical service that will give them a chance to have a good vision. So today we will listen to the talk of Dr. Oganessian about keratoplasty. And if you will have any questions, you can put them in the questions or here in the chat. And we will be glad to answer them after our webinar. Thank you.
Dear colleagues, I'm glad to see you. I'm grateful to everyone who joined us. Today, I'm happy for the opportunity to share some insights on DMEK. Let me introduce myself. My name is Oganessian. My area of interests are the anterior segment of the eye, also cataract surgery, reconstructive surgery, but first of all, I am a keratotransplantologist. Okay. 18 years ago, I was lucky and honored to be one of the first who studied and mastered endothelial surgery technique in NEOS. Before moving on to the DMEK, let's go back to the keratoplasty history, or if you want, keratoplasty evolution, to understand the revolution in transplantation that happened 25 years ago. Here I show the main names, dates, and events thanks to which organ and tissue transplantation and corneal grafting in particular became possible. In 1913, Carl Himley proposed grafting clear cornea animals to blind animals. Franz Reisinger did first penetrating keratoplasty on an animal and proposed xenotransplantation. Richard Kissam did first xenotransplantation from a pig in New York City. In 1930, Van Volter offered lamellar keratoplasty. Later, William Morton gave first general anesthesia. Semmelweis and Joseph Lister developed the principles of asepsis and antiseptics. In 1884, Karl Kjöller offered local anesthesia for eye surgery. Von Hippel offered circular trephine, and finally in 1905, Edward Conrad Zirn did the first successful allograft penetrating keratoplasty. In fact, Dr. Zirn was not only the first person to perform a successful corneal transplantation, but also the first one to perform a multi-transplantation as an example of rational use of donor tissue. He did 2 penetrating keratoplasty from a single donor tissue. In 1931, Professor Filatov in Odessa offered cadaveric donation. And in 1944, Richard Patton founded the first eye bank in Manhattan. 20th century was the golden age of the penetrating keratoplasty, but it ended 25 years ago. The development of focus surgery, refractive technologies, and microinvasive surgery in general have opened our eyes to obvious disadvantages of penetrating keratoplasty, such as the sutures and the need to remove them, post-penetrating keratoplasty astigmatism, open sky surgery, long-term rehabilitation, difficulty of combined surgery, refractive error in triple procedure, the need of general anesthesia. In addition, the surgical scar after PK is not strong and is always dangerous in case of blunt trauma. Nowadays is the era of selective keratoplasty aimed to removing and replacing only the affected tissue and preserving healthy corneal tissue. Harriet Mallis is the godfather of modern endothelial keratoplasty. It is him who developed all modern techniques of endothelial surgery and bone layer transplantation as well. He also offered trypan blue staining in cataract surgery and in corneal transplantation. The first technique was PLK, posterior lamellar keratoplasty, and DLEK, deep lamellar endothelial keratoplasty in USA. The idea of PLK is to remove recipient posterior stroma, Descemet membrane, and endothelium by peripheral access, and so creating bed on the posterior surface of the cornea and sutureless fixation of the donor graft contain stroma, Descemet membrane, and endothelium. You can see the borders of the graft inside of cornea. This is one of my first PLK cases, 17 years follow-up. PLK has a very challenging surgical technique. For this reason, Mallis developed Descemetorexis and DSEK technique. The idea of DSEK is to remove only Descemet membrane and endothelium of recipient, and sutureless fixation of the donor graft contains stroma, Descemet membrane, and endothelium. Ultrasyn DSEK, femtosecond DSEK, excimer laser DSEK, inverted femtosecond DSEK, and others have been developed later based on regular DSEK. DSEK has quite an easy surgical technique, and at the same time, it has significant disadvantages such as increased corneal thickness, hyperopic shift, limited visual acuity, graft dislocation rate, rejection rate, interface quality, etc. For these reasons, Mallis developed DMEK technique, Descemet membrane endothelial keratoplasty technique, which is the most effective technique of endothelial keratoplasty. The idea of DMEK is to remove only Descemet membrane and endothelium of the recipient and to fixate the donor graft containing only Descemet membrane and endothelium without sutures. DMEK and DMEK-S have been developed based on regular DMEK. It is a combination of DMEK and Descemet. The main DMEK disadvantages are challenging surgical technique of roll unfolding and challenging surgical technique of graft harvesting without tissue tearing. DMEK's most common complication is graft detachment. DMEK advantages are following: no astigmatism, best visual acuity in the shortest time, intact corneal architecture, fast recovery, closed surgery, no sutures, low rejection rate, repeated DMEK at any time, no need for expensive equipment. Also, DMEK technique permits use donor cornea after refractive surgery. For example, here we can see the donor tissue after radial incisions. DMEK technique allows to vary the graft size and graft shape. QDMEK, QDMEK, is a modification of regular DMEK that allows to perform 4 DMEK surgeries with single donor cornea. The surgical technique did not differ from our conventional DMEK technique. In a few words, a main limbal tunnel incision of 1.6 millimeters, making with a single paracentesis at the 10 o'clock position. Descemet Rex is performing under air, always bigger than the graft. The Q graft injecting into the host anterior chamber through the limbal incision, positioning centrally with the endothelium facing down and the anterior chamber completely filling with air. The technique of grafts preparation is following: Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork is kept intact and pulled together with Descemet membrane. After staining Descemet membrane, the tissue is positioned stromal surface down onto a soft contact lens, which is put on a bottom punch. The peripheral rim with the trabecular meshwork is removed. We use a custom-made punch for linear cutting of Descemet membrane and obtaining 4 quarter pieces. We can even use single cornea tissue for 5 recipients for 1 deep anterior lamellar keratoplasty and for 4 quarter DMEK. Theoretically, the number of transplantations can be increased up to 6 if donor limbal tissue is used for other limbal transplantation. Here are images before 1 and 4 weeks after QDMEK. The next modification is hemi-DMEK, which allows to perform 2 DMEK from 1 donor cornea. The surgical technique did not differ from our conventional DMEK or quarter DMEK techniques. We can use 1 cornea tissue for 3 recipients. Stroma can be used for DALK and Descemet membranes for 2 hemi-DMEK. Performing QDMEK and hemi-DMEK is absolutely logical. because the pathological changes in Fuchs dystrophy are mainly limited to the central zone of the cornea. That does imply, however, that strict case selection for QDMEK is necessary. In addition, QDMEK allows retention of more host cells. At the same time, it creates favorable conditions for endothelialization because the Descemet rhexis in partial DMEK cases is always bigger than the grafts. Partial DMEK has some drawbacks: an acceptable increasing time for grafts preparation, limited indications, prolongation of recovery time, and requires strict case selection and good logistics. So, split and divide approach can reduce the need for corneal tissue. The main advantage of QDMEK and HemiDMEK is in a much more efficient use of donor tissue. Such approach could help dramatically reduce the shortage and the cost of corneal tissue. Strict case selection is necessary. More case and long-term data are required. One more DMEK technique is 3/4 DMEK. So it is well known that glaucoma drainage devices is a disadvantageous factor for graft survival after PK. Also, secondary graft failure after DSEK and DMEK in eyes with glaucoma drainage devices occurs in up to 35 to 74% of eyes at within 24 months. The rate of graft failure in eyes with glaucoma drainage devices is significantly higher than in eyes after glaucoma surgery without glaucoma drainage devices, and even more so in eyes without glaucoma surgery. The endothelial cell loss after DSEK in eyes with glaucoma drainage devices is around 61% during the first year, which is much higher than in eyes without glaucoma drainage devices. According to literature, graft failure in eyes with glaucoma drainage devices occurs earlier after DSEK than after PK. The mechanisms of endothelial graft failure in eyes with the glaucoma drainage devices is poorly understood. The most possible explanation might be mechanical damage of the donor endothelial cells by an intermittent or constant touch between the silicone tube and the graft. Other possible mechanisms include chronic pro-inflammatory, pro-apoptotic state of cells, chronic uveal inflammation induced by tube to iris contact, and glaucoma medication toxicity. There have been few case reports of DMEK for eyes with glaucoma drainage devices tubes. Larger cases show good earlier outcomes, but high failure rates over the long term. Earlier, we introduced a 3/4 DMEK technique for optimizing the separation between the graft and the glaucoma drainage device silicone tube for treatment pseudophakic bullous keratoplasty. The technique of graft preparation is following: Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork is kept intact and pulled together with Descemet membrane. After staining Descemet membrane, the tissue is positioned stromal surface down onto a soft contact lens, which is put on a barm punch. The peripheral rim with the trabecular meshwork is removed. 2 perpendicular cuts performed with keratome directed to the center, and triangularly shaped portion of Descemet membrane cut out. The absence of the graft under the tube prevents the contact between the silicone tube and the graft, which could lead to chronic endothelial cell loss and graft failure. On patient's eye, Descemet is creating under air, but with the part of the Descemet membrane under the silicone tube left untouched. The graft injecting into the host anterior chamber through the main incision, position centrally and partially unrolling to achieve visualization of the site with a missing part, with a gentle tapping of the cornea to rotating the graft in the anterior chamber, such that the missing portion of the graft relocating to the silicone tube projection. After the graft completely unfolding, the anterior chamber filled with an air. The absence of the graft under the tube could help avoid the contact between the silicone tube and the graft. Such contact after conventional circular DMEK may induce chronic endothelial cell loss and graft failure. To avoid or minimize cell migration from the graft onto the recipient stroma, the part of the host Descemet membrane under the silicone tube is left untouched. The absence of chronic donor endothelial cell migration to the tube region may help retain the pool of donor endothelial cells on the graft itself. Using large diameter graft may compensate for the missing tissue quarter in terms of absolute cells numbers, especially since large diameter grafts include the corneal periphery, in which the endothelial cell density is much higher. This is my last slide in this presentation. So we demonstrate the technical feasibility of 3/4 DMEK in eyes with pseudophakic bullous keratoplasty in the presence of a glaucoma drainage devices tube. The absence of a donor Descemet membrane and donor cells above the silicone tube excludes direct tube contact with the graft. Of course, longer-term studies are needed to show the effect of this modified graft pattern and dimensions on transplanted survival. Dear colleague, thank you for your kind attention. Thank you. Goodbye.
Thank you, Dr. Oganisyan, for a great talk. I think it will be very interesting for our colleagues to know all these aspects of keratoplasty And yesterday we had sent very interesting research on the keratoplasty that we have from different countries. And for example, for sure, it is very important topic that need to be discovered in future. If there is any questions, we can ask to Dr. Oganisyan. And I want to say that we will be glad to see you all in our clinic in Bahrain, in Crystal Vision Clinic. Uh, we will be happy to share with you with our services and to share with our practice that we had bring from Russia. So next Wednesday we will also have a webinar at 8 a.m. and the topic and the speaker we will share during this week. So have a good day and thank you for having us today in the morning. Thank you.